We can start with questions for our presenters.
I've got a question for Dr. Zhang. That was a nice summary of sort of recently pushing the field further for more inclusion in acute therapies. Based on what we've seen with the data that's been presented, would you change your paradigm of screening patients with extended window?
Yeah, I think I think the data is now strong enough with other studies as well that suggests a non-contrast CT. I think, what was the other study? It was CLEAR is the other study where they showed non-contrast CT was non-inferior to using these advanced imaging techniques. At least for these very proximal elbows, like ICA, proximal M1, I think a non-con CT and you prove that there's an occlusion, you should probably be going after these patients, regardless of what. The CTP may be nice to help with like prognostication, because you can say, hey, your core was this or this, but even then, Aspects is pretty good at prognosticating as well. So if I personally, if I see a IC or MCA within 24 hours, I probably would just open these patients.
Just want to follow up on that. 12 hours is kind of an interesting threshold because that's about the time when we sometimes catch people that have been waking up.
Yeah.
And they go to bed at, say, 8, and we're seeing them at 8 the next morning, something like that. And that was maybe a tipping point between Tesla being positive and not being positive. So if you were to look at that difference between, say, Tesla and tension, do you know from any data that they've presented whether what caused it to be less positive was the later presenters? Right.
I would only be speculating because the paper hasn't been published yet, so I only am going off what the articles regarding the presentation itself, because I didn't attend the conference either, so I'm just going off the initial, but I don't know exactly the details.
Question for Dr. Yeager. When this RNF213 is kind of a fascinating, connection with moya moya, and when we think of our patient, and you mentioned there's kind of the bimodal age distribution, most of our patients who are new diagnoses are 20s and 30s. They must have something about their phenotype that's a little bit, protective. Might there be, or has there been any opportunities for gene modulation or medical management of those patients, to keep their disease mild so that they don't progress to severe moya moya?
Yeah, that's a great point. The answer is no, there hasn't been any, but I think that's the next direction we can go. Yeah, that's the bad part about it is we just don't have a way to target those yet. But the fact that, like I said, the two-hit hypothesis, there's some kind of inflammation going on as well. Some of these patients have an increased, they have increased complements, they have increased inflammatory levels, infection. There've been studies looking at the people with moya moya have increased infection. So those are all kind of part of the same cohort, I think. But yeah, not yet. There's no medical management, but I think that's coming down the road for sure.
Dr. Yeager? I'm sorry,
Yeah.
sitting around the corner. Just clinically speaking, I mean, if we're getting larger proportions, because when we were like in med school, mostly a white population, we're like moya moya was this bizarro, weird thing, which it didn't correlate to what I was seeing, like my Japanese side of the family, those relatives. It seemed like it's a higher rate. You mentioned the triptans that we use for migraines. How many people come in? I mean, we can't scan everyone's brain that has a headache, but a lot of times, should we be screening our Asian patients who come in and say, oh, I have these horrible headaches differently than our standard population?
Yeah, that's a great point. I don't think there's any, I didn't come across anything regarding screening, but I think if people, if people do have, because there's definitely different presentations, there's ischemic presentation, hemorrhagic, but then, incidentally found. I don't know of any screening, but I think it's not a bad idea to keep that in the back of your mind if you do have a patient with East Asian origin, to think about that as a possibility.